at the University of Delaware in the Department of Physical Therapy, and she's going to talk to us about her limb pain post-amputation. So Megan, take it away.
Okay, so thanks so much for having me today, and I'm assuming everybody can see my slides there. But residual limb pain, it's pain that occurs in the limb after the amputation and the part that's remaining. And really what this pilot project that was funded by Excel looks at is how do people detect vibration and what frequencies do they detect in that limb and also in their limb that has not been amputated, and how does that relate to balance? And so kind of the whys about that. So 74% of people that lose their limb are going to have this long-standing pain in their amputated portion of their limb. And we know that in other patient populations, chronic pain, specifically in patient populations such as low back pain, fibromyalgia, these individuals have somatosensory changes. And what I mean by that is when you touch them, they have an altered touch perception. They also have decreased ability to tolerate pressure when you touch them, and they're unable to detect, in some cases, vibration, or their vibration sensitivity decreases. And so specific to people with lose their limb, we know that the inability to feel vibration is a risk factor for decreased balance and also a unique risk factor for falling. So each year, about 50% of adults with lower limb loss will fall, and we know that balance tests can be used to evaluate fall risk in adults with lower limb loss, specifically in clinical practice. But really to date, there hasn't been any research looking at vibration detection and these clinically used balance tests. And we thought it was important to really look at this in people that have lost their limb and those with and without residual limb pain, because this pain may actually affect their ability to detect vibration. And when you think about the application of that potentially to practice or future innovation, you could think about the vibration that occurs in your cell phone. So you can now set your vibration in your cell phone to identify the person who's calling you so that you don't actually have to look to see their name. Well, similarly, we can set prosthetic technology to inform the user about the type of floor surface that they're walking across. So for example, are they walking across linoleum or carpet? And that this then changes their foot clearance and may help to reduce their risk of falling, essentially. So in this pilot project, we're looking at differences in vibration detection between both the sound limb and that residual or amputated limb in individuals both with and without residual limb pain. And we want to look at also the differences between these two groups. And then we want to evaluate the associations between the ability to detect vibration and these different clinical balance tests, while considering potentially that there could be an interacting effect from the presence of pain. So participants for this project are being included if they're at least 18 years old, they have to have a single below the knee amputation, and they have to have a definitive prosthesis, which typically occurs in the later part of year 1, early year 2 after their amputation. They have to be using their prosthesis a substantial number of hours a day, and they have to have had their amputation at least 1 year prior to allow for healing. We exclude individuals with major sound limb amputations if they're using a walker, if they have certain conditions such as Parkinson's or multiple sclerosis, because we know that those conditions may affect somatosensory function, and if they have issues with their residual limbs. So for example, if they have an ulcer and they're unable to participate safely. So this is a cross-sectional study design, and we're conducting standardized interviews. We're using this scale called the Houghton scale of prosthesis use to look at walking ability. It essentially tells us how our patients are performing in terms of are they more household ambulators or community ambulators. We're also asking them to rate the residual limb pain intensity from a 0 to 10 scale, and we define that as pain in the remaining portion of the limb. And then we complete 1 self-report measure and 3 balance measures that are performance-based, and look at vibration sensitivity testing. So we selected for our self-report measure the activity-specific balance confidence scale. This is a 16-item scale that's reliable and valid in this patient population. You can see here that 0 is no confidence with different tasks with regards to steadiness, and 4 is complete confidence. And so higher scores indicate better balance confidence. For performance-based tests, we use the timed up and go. This is a functional mobility test. The individual is asked to sit in a chair, stand up, walk to a line 3 meters away on the floor, turn around, walk back, and have a seat in the chair. They can use their assistive device if needed. It's been shown to be reliable and valid with the average of 2 trials. In this case, lower times or faster paces indicate better performance. For the 4-square step test, we asked them to complete this sequence where they step 1 to 2, 2 to 3, 3 to 4, 4 to 1, and then completely in reverse as quickly as possible, facing forward if possible the entire time. So they're trying to clear these sticks without touching them to have a valid test. We've established previously in our lab test retest reliability for this measure for those with lower limb loss. They can use an assistive device if needed, and we take the average of 2 trials. Again, faster times or lower scores are indicative of better performance. And then we use the Berg balance scale, which is widely used in the rehabilitation community. It's a reliable and valid battery of tests. So there's 14 items, and you can see some of those items here. So we have tandem stance as shown in the picture at the left, and then on the picture at the right, we have the toe tap test, which is the most difficult of the tests that they're asked to do. So here, low or poor performance would be a 0 for each item, and high performance would be a 4, and then overall higher scores indicate better performance. So for vibration sensitivity testing, we actually developed a new procedure or protocol using a Vibratron 2. This is based off some of the literature that's been used in diabetes previously. So with this particular device, the resolution is about 0 to 20 vibration units, also called microns. And we do a trial run on the patient's fingertips so they can become familiar with the vibration, what we're asking them to do. We then apply the vibration to the mid-patella, as shown in this picture at the bottom here. And essentially, we start up at about 20 vibration units or microns, and we reduce until the patient can no longer feel the vibration. So we do that 5 times and then average the trials. And so the lower microns that they're able to feel, so the lower vibration units, the better sensitivity, so the better they're able to detect vibration. For data analysis, we're using SPSS statistics. We're looking at the differences in vibration detection between the sound limb and that amputated limb, and also between groups, so between those with and without residual limb pain. And then we're looking at correlations between their ability to detect vibration and these different balance tests. So here you can see that we've recruited so far 12 individuals with residual limb pain out of our sample target of 25 and 21 without residual limb pain, with our target again being 25. And you can see that generally speaking for characteristics, it's very similar between the two groups at this point in time. As expected, our individuals without residual limb pain tend to be more likely to be community ambulators, and that's per that Houghton scale of prosthesis use, as compared to lower scores tend to indicate household mobility. But still the scores are quite high, and so I would say the sample as a whole are generally community ambulators. If we look at pain intensity at the time of testing, it's about a 2 out of 10, so relatively low for these individuals with residual limb pain. For our balance test, there are no significant differences at this point in time between those individuals who have pain in their residual limb versus those who don't. And interestingly, we also don't see differences so far in vibration sensitivity between those with and without pain. We also have used a paired t-test to look at within subject group differences in sound versus residual limb. And essentially what we see is that there's no difference between the sound limb and the residual limb in those with or without pain. So there don't seem to be these differences that perhaps we expected to see. But what we did find to be interesting really lies into the correlation part of this study. So here we can see that for activity-specific balance confidence scale, that it's not correlated to vibration sensitivity. So remember, this is a self-report measure. And this is true for both those with pain and without pain. But when we look at residual limb pain group and we look at the sound limb, again, we see the same trend, that the performance-based tests are not correlated or associated with vibration sensitivity in the sound limb. But interestingly, for the more challenging balance tests, for the 4-square step test and Berg balance scale, we see that the performance on these tests, so better performance, is associated with better vibration sensitivity for those individuals that have residual limb pain. And when we look at those without residual limb pain, we see a similar trend in that these balance tests are correlated with vibration sensitivity for both the sound limb and the residual limb. And so really what that means is that vibration detection seems to be pretty similar between the amputated limb and the sound limb, and it seems to be similar among adults with and without residual limb pain. And interestingly, it's not associated with self-reported balance confidence, which is one of the measures that appears to be associated with fall risk. So adults with and without residual limb pain with better residual limb vibration sensitivity have better overall balance performance. And this has some clinical significance in terms of, can we retain the vibration sensitivity in that residual limb? And in terms of adults without residual limb pain with better vibration sensitivity in the sound limb, they also have better balance performance. So what this means is that if you don't have residual limb pain, you probably are going to do okay because you have two limbs to rely on in terms of either the sound limb or the residual limb giving that vibratory feedback. But if you have residual limb pain, you're now more susceptible potentially to balance and falls issues because this residual limb vibration sensitivity is significantly correlated to balance performance. And the significance of this is that this foundational knowledge regarding vibration detection among adults with lower limb loss can be used to inform future prosthetic technology. And as I said before, we may be able to use this information to help to provide different biofeedback for different floor surfaces, thresholds, etc., to enhance balance and reduce fall risk in individuals with lower limb loss. And in particular, this may be critical for those with residual limb pain to make sure we're giving appropriate biofeedback in that limb that is wearing the prosthesis. So I'd like to just acknowledge Excel and Dr. Bender McLeod, for the grant support, as well as my PhD student is funded under Dr. Steiner-Mackler's training grant. That's all I have. Thanks for listening.